थोड़ा माइटल स्टेनोसिस में MDM होता बोल के समझ गए तो जाके हर एक के ऊपर स्टेप लगाओ, where is it, keep searching, you will find. If you know fresh frozen plasma is given to replenish the clotting factors, keep running around the hospital in the medicine ward, where is the FFP flowing, your medicine postgraduate will show you, please come, this is called platelet infusion which I am giving, please come, this is called as FFP which I am giving to this patient, you will be happy to share with you, provided you already know what is FFP, what is cryoprecipitate, what is PRP, what is whole blood, what is packed cells, what is the difference between them, what is the constituent of each of them. If you already have that basic knowledge, don't expect it to be taught by your postgraduate. What you can read need not be taught, and what can be taught may be missed in spite of reading. So that is a whole problem. So there is a reason, read well and go with an open mind. You can use your ward nurse, ward boy, postgraduate, HOD, anybody who is available for you to acquire that extra patient knowledge. Obviously, if I am, suppose I am a surgery postgraduate, tomorrow we are doing a cholecystectomy. Typically it is not a gallstone, it is a gallstone, not a calcium gallstone but a bilirubinate stone in a patient of hereditary spherocytosis. I love to demonstrate to you, provided you already know what is hereditary spherocytosis, where is the problem, why bilirubinate stones form, what are the different types of gallstones, वो सब रहता ना पीछे का knowledge. That knowledge brain में रख के if you go, anybody will show. Okay doctor, so that's the reason post dinner mess में खाने के बाद go for a walking to the hospital, walk into the casualty. You will have lot of patients, painful joints, fractured clavicles, femur dislocated, hemophilic patients, stroke patients, patients who are not receiving aspirin, who receive too much aspirin and bleeding. Like Yamadharmaraj, you walk into the casualty, that's how medicine is revised, doctor. That's how medicine is revised. There is no conventional way of learning. War, love and medicine, it's all out of box thinkers learn better. If you think that there's a very standard way of doing things, standard way of learning, no, it won't happen. So isliye tomorrow only you go and see how is the complete. Now almost we finished medicine, no? We read nephrology, we read pulmonology, we read cardiology, we read neurology, so many things, no? So revision of it is good, provided 1 to 2 hours go for K shopping, it is called as K shopping. चलो भाई एक aortic regurgitation दिखाओ, अच्छा ये aortic regurgitation है क्या, ठीक है, चलो step लगाओ and try to see whether how many signs of AR or hyperdynamic circulation you are able to listen. Is there any Austin flame? Is it a serious AR or mild AR or moderate AR? You will have all reports of the patient on the 2D echo. Just you need to clinically examine. 10 ARs if you see, that is already diagnosed cases of AR. In exam hall you won't be, lack of confidence will never be there. In contrast, you have invested your time in reading 50 pages about AR in Harrison and go, if your patient's carotid is dancing also, you won't recognize that he is a case of AR. So that is the reason always there should not be any overdose of knowledge and underdose of clinics. There can be overdose of clinics with an underdose of knowledge is okay. You can err on that side. Okay, doctor? So renal papillary necrosis. How do you identify renal papillary necrosis in a sickle cell anemia patient? We studied, no? If there is any papillary necrosis, tubular damage, concentrating ability of the urine is lost and it reflects in the form of isostenuria, fixed specific gravity, whether patient is dehydrated or overhydrated, same specific gravity is a classical feature. Patients can develop chronic leg ulcers, abdominal crisis. These leg ulcers are very important. Tell me, doctor, what are all the various causes leg ulcers can occur? Diabetic ulcers, varicose veins can lead to venous ulcers, sickle-cell anemia can lead to leg ulcers, there can be decubitus ulcers, etc., etc. And DVT patients, post-thrombophlebitic syndrome, they can develop leg ulcers because there will be hypoxia to their skin of the lower limbs. So there are all the various causes. Now coming to the infections, when there is no spleen, there is no properdin. Properdin is important for opsonization of the organisms. What is meant by opsonization? When an organism enters, its capsule may not stimulate antibodies. इडली के लिए चटनी चाहिए उसको टेस्टी बनाने के लिए. Organism को टेस्टी बनाने के लिए you require opsonization which is done by properdins. Properdins which are released by the spleen. If there is an autosplenectomy, there will be properdin deficiency which will prevent opsonization and increases the capsulated organism infections like streptococcus and salmonella and H. influenza is what need to be remembered. And a sickle cell patient will have a delayed growth and sexual maturation is what need to be remembered. So how many crises that you have seen? A plastic crisis, vascular vaso-occlusive crisis, then you have a splenic sequestration crisis which can occur within the, there can be sudden pooling of the blood in the spleen in the children in whom the spleen has not yet undergone autosplenectomy. Now there is a classical story of a patient who had an autosplenectomy. Normally what is the role of the spleen, doctor? RBC break होने के बाद all that hemoglobin residues which are there in the RBC will be extracted and removed by the spleen. If there is no spleen, then the cells will be containing those chromatin remnants in the form of inclusions called as Havel-Jolly bodies. Presence of the Havel-Jolly bodies is an indicator of absence of the spleen is what need to be fundamentally remembered. Now, how to diagnose sickle cell anemia? It's an anemia. Peripheral smear can show sickling. Sometimes you can use metabisulfite to induce sickling and see that it is there. That is one way. And how do you treat? Avoid hypoxia, maintain fluids, prevent infections, and give a early vaccination with capsulated organisms. Give prophylactically penicillin to the children until 6 years starting from 4 months, because infection is a common predisposing factor for a sickling crisis. So hydration, kill the pain with morphine, keep the patient warm and prevent hypothermia and give supplemental oxygen is the main part of the treatment. Now, is there any drug which can be used to prevent sickling or decrease the amount of sickling? You can give hemoglobin, hydroxyurea. Why hydroxyurea is used? Because sickling is a problem in which chain, doctor? Beta chain. HbA has alpha 2, beta 2. HbF doesn't have beta but alpha. Increase the amount of HbF, so that will decrease the amount of HbA and decrease the number of cells which are vulnerable for sickling. Okay, so that is how hydroxyurea, by enhancing the HbF content, is useful in the management of prevention of sickling is what need to be remembered. So this is the classical story. Before hydroxyurea and after hydroxyurea, what is the effect of giving the hydroxyurea? By giving hydroxyurea, the number of sickled cells are decreased because HbA levels will decrease and HbF levels will increase is what need to be remembered. In some people, bone marrow transplantation has a role, and ultimately gene therapy also gives the hope. Finally, for MBBS final exam, what are you going to remember? 5 points. What kind of mutation? Valine to glutamate, glutamate to valine, that is important. Beta 6 position, hydroxyurea in the treatment, different types of crisis, and encapsulated organism infection. They are the buzzwords which you are not going to forget. Now, doctor, the next important entity is called hereditary spherocytosis. Very simple. In this, there is a problem in the spectrin, which is one of the important protein on the membrane of the RBC. If there is no spectrin, RBC cannot be packed like a biconcave disc and it converts into a spherocyte. And always a biconcave disc will have a larger volume of space available, unlike a sphere which can accommodate less amount of volume. I think the only place where our geometry, which we studied in 9th and 10th class, will be helpful is hereditary spherocytosis. Now, these spherical RBCs will be broken down by the spleen, because spleen will say, अरे क्या है इतना मोटा मोटा cells अंदर जाना नहीं हो सकता, biconcave है तो you are flexible. Then it will say, kill him because he is fat, and that's how hemolysis will occur. Other than hereditary spherocytosis, what else will be responsible for the appearance of the spherocytes in the peripheral sphere? Even G6PD deficiency, hyperthermic guys, autoimmune hemolysis or ABO incompatibility, they are the other causes where there can be development of spherocytes in the peripheral smear. But why is this important? If you do the Coombs test, how will it be in hereditary spherocytosis? Give me one guess answer. Coombs test, negative. It has to be, it must be, it should be. If it is not hereditary spherocytosis. Coombs negative anemia, which spherocytes is hereditary spherocytosis. Coombs positive anemia, which spherocytes is autoimmune hemolytic anemia. Favorite question of the examiner. How do you differentiate hereditary spherocytosis from that of autoimmune hemolytic anemia? Coombs test positivity is a very important differentiator.